Hey team, welcome back. This is Nurse Eunice with Florida Training Academy, and in tonight's video, we're going to be covering medical conditions for nursing students. Why nursing students? Because a lot of our CNAs are now entering nursing school. And so we want to help you bridge that gap to transition from CNA to nurse. And we're going to do it together. So we're going to give you a few moments to receive your notifications, and we will get started in 5 seconds. All right, so everybody, tonight on this channel at 9 p.m., we're going to have Night Shift with Nurse Eunice. I want to have weekly communications with you all to check in and see how you're doing, to congratulate you on passing your examinations, on getting accepted into nursing school, getting your first job. So we are friends. So I want to learn more about you as you learn more about me. So join me tonight on YouTube, on Facebook, 9 p.m. Eastern Standard Time. So Night Shift with Nurse Eunice. Let's chat. I love this image. This is one of our nursing babies. So here in Jacksonville, Florida, we have an NCLEX and a nursing clinical skills lab. So some of our NCLEX retesters, some of them, it's been 10 years since they've finished nursing school. However, they come to us, they've passed their NCLEX, or they're going to be retaking their NCLEX soon, but they haven't performed their skills in years. That's where we come in. We're a safe place for you to learn. You're going to be challenged. It's a 2-day course for $500. But if you have a challenge once you finish nursing school, if you're unable to pass your NCLEX, not only do we provide the NCLEX test prep online, but in addition to that, we also have the hands-on skills refresher and IV therapy courses for nurses. So I look forward to working with you. All right, so let's talk about this test, medical conditions practice test for nursing students. This practice test is helpful for you because it reviews important medical conditions that you need to know. It gives realistic questions like those that'll be on your future exams. These may not be your NCLEX type questions, but you have to finish nursing school. You have to know about anatomy, physiology, med surg nursing, intensive care. You have to know your lab values. So we're going to start introducing that in mini lessons, and we start tonight. It's also going to help you build your confidence for test and clinical practice. Whenever I give the answer to a question, I give you a rationale so you have something to refer back to. And so this is going to help you see what you already know, but it's also going to help you review and prepare for nursing school. And so overall, it's just an easy way to practice, to learn, and to feel prepared. Plus, it's fun. You're here with your other friends. We're all on YouTube. We're on Facebook. We put the answers in the chat. And if we're wrong, it's okay. It's a safe place to learn right here. All right, so let's get ready, team. Find a quiet space to focus. I know some of you all actually be working. You're doing your 12-hour shifts while you're listening to my videos. I thank you, but if you could just step away, get a piece of notebook paper and a pen. We're going to read each question carefully, and then we're going to jot down some notes. If you have time, if it's safe for you to do so, I want you to put your answer in the chat. All right, let us begin with question number 1. A client is diagnosed with congestive heart failure, or CHF. Which of the following is a classic sign of left-sided heart failure? Is it A, jugular vein distension, B, peripheral edema, C, pulmonary crackles, or D, hepatomegaly? So when the left side of the heart is failing, how will your patient present? All right, revealing the answer in 3, 2, and yes, it is C, pulmonary crackles. So whenever the left side of the heart starts to fail, your patient's going to have pulmonary congestion. So they're going to have that wet cough. If you auscultate, if you listen with your stethoscope, you're going to hear crackles. You can sometimes hear wheezing. And if it's really bad, they can have blood-tinged sputum. And they're going to have faster rates of breathing, or tachypnea. If you lay them flat, they're going to be short of breath. We call that orthopnea. So a lot of respiratory conditions happen whenever the left side of the heart fails. And so here's our rationale. Left-sided HF is heart failure, causes fluid back up into the lungs, resulting in pulmonary congestion and crackles. Question 2. A client's labs reveals a sodium level of 120. What is this called? Is it hypernatremia, hyponatremia, hyperkalemia, or hypokalemia? All right. So when we're referring to sodium, is that natremia or kalemia? Let's learn our terminology. Revealing the answer in 3, 2, and a sodium level of 120 means that your patient is hyponatremia. So sodium level less than 135 is considered low. So 135 or less, that would be hyponatremia. And what do you think your physician's going to order? If you said IV fluids, normal saline, which has sodium chloride, you're correct. All right. So, all right, question number 3. The most important intervention for a client with diabetic ketoacidosis or DKA is it A, begin an insulin infusion, B, give IV potassium first, C, give sliding scale insulin, or D, restrict oral fluids? What is diabetic ketoacidosis? How does that differ from just being diabetic? All right, so they are somehow acidotic. What's going on with them? All right, so when a patient has DKA, they have severely uncontrolled blood sugar levels. We need to start an insulin drip. So the answer is A. Give yourself a round of applause. Priority is to lower the blood glucose with insulin. In DKA, the body is in a state of insulin deficiency, resulting in a very high blood glucose level and the breakdown of fat into ketones. And the breakdown of those ketones, or that fat, that is what causes them to become acidotic. And so the most effective way to stop the ketone production and the acidosis is to help the body use glucose properly. So we have to administer insulin. However, we don't have time right now for subcutaneous insulin to start working. We're instead going to start an insulin infusion. And so don't forget that whenever a patient is receiving insulin, you also have to monitor their potassium. So we're going to get what type of panel, what type of lab work should we be ordering? If you said a BMP, a basic metabolic profile, or CMP, which is a complete metabolic profile, you're absolutely correct, because it's going to show those electrolytes. All right, question 4. A nurse is educating a client with chronic kidney disease, or CKD, about their diet. Which food should they limit most? Is it apples, chicken, rice, or bananas? And I know my CNAs know this because we talk about the dietary requirements of patients with, specialized diets all the time. So when someone has chronic kidney disease, they can't excrete certain minerals, certain electrolytes. And this one in particular can cause them to have an abnormal heart rhythm. Which one is it? If you said D, bananas, because it's high in potassium and people with chronic kidney disease can't excrete that potassium, you are right. And so they're going to have a low potassium diet. Therefore, in your hospital during the stay, they will not be getting bananas. Question 5. Your client with pneumonia has an oxygen saturation of 89% on 2 liters per minute via a nasal cannula. What is your first action? So 89%, 2 liters of oxygen. Would it be A, call the provider, B, encourage insulinspirometry, C, increase the oxygen to 4 liters per minute, or D, auscultate the lung sounds and assess for increased work of breathing? What do you think the nursing intervention would be? I'm giving you about 2 more seconds with this one. All right, revealing the answer right now in 3, 2, and that is right. Because when you call the doctor, you have to call the doctor with more than just what the monitor says. How is your patient presenting? So it is D. We're going to auscultate. We need to listen to the lung sounds. Do they sound tight? Are they wheezing? Do they have crackles? When a patient with pneumonia is hypoxic, your first priority is to assess the patient before making any interventions. You need to quickly check for signs of respiratory distress, which include increased work of breathing, use of accessory muscles, and cyanosis, or the turning blue. Remember, brown skinned people such as myself, we don't turn blue, but you can tell when our oxygen saturation is low, we get this grayish, this really pale look about us. And so for us, it's not blue, but you can definitely tell there is a change in our coloration. And so when you auscultate those lung sounds and you report all of that to the physician, that is when a physician will let you know, hey, maybe we need to increase suctioning. Now we have an order to titrate or to give more oxygen, and we could need other treatments or diagnostic tests such as a chest x-ray. And so to once you have assessed, then you can make an informed intervention such as increasing oxygen and or notifying the provider if findings are concerning. Question 6. A client with deep vein thrombosis or DVT is receiving a heparin drip. The most important lab value to monitor is which of the following? Would it be A, a PT-INR, B, platelets, C, PTT or APTT, or D, BUN? And if you don't know what any of those mean, write them down so that you can go back and review later. All right. And so when a patient has a deep vein thrombosis or a clot in the deep vein, usually in the leg, and they're receiving heparin, which is an anticoagulant, what lab value will you be monitoring? It'll be C, PTT/APTT. So heparin therapy is monitored by APTT or partial thromboplastin time versus warfarin. That is when you would be monitoring the PT-INR levels, and warfarin is oral. So whenever a patient has a blood clot, we start them off on either IV heparin or subcutaneous heparin. And in addition to that, when it's time for discharge, your doctors will start them on their warfarin, the oral anticoagulation medication. And so that is going to, in the hospital, get them therapeutic, make sure their blood is thin, and then we can transition to the oral in time for discharge. Question 7. What is a normal fasting blood glucose level? Would it be A, 50 to 80, B, 70 to 110, C, 100 to 150, or D, 150 to 180? And then the mg/dl would be milligrams per deciliter. In healthcare, we don't usually say that. We just say, hey, the blood sugar is 78. Okay, so which of the following ranges would be normal for a fasting blood glucose level? That means that this patient went to sleep at 8 p.m. and now it's 8 a.m. and they haven't had anything. They've gone more than 8 hours without food. Yes, team, it is B. It is 70 to 110. So a blood glucose level of 70 up to 110 is normal for a fasting blood glucose. And if you've stayed this long and you haven't liked our video, shared our video, or subscribed, what's stopping you? Go ahead and do so now. You all, we are so close to having 1 million subscribers, and I know we can do it with help from friends like you. So don't forget to like, share, and subscribe, and make sure you give us a thumbs up. Question 8. A client with cirrhosis is most at risk for which complication? Would it be A, hepatic encephalopathy, B, pulmonary edema, C, stroke, or D, diabetes? All right, so what organ is affected by cirrhosis? And based on the organ, what type of complication would your patient have? Yep, I see correct answers. It is A, hepatic encephalopathy. So look at that image. Look at how yellow that person is. And so that yellowing or that jaundice is a sign of liver failure. So whenever someone has liver failure, it could cause jaundice. It could cause hepatic encephalopathy. But here is our rationale. Cirrhosis impairs the liver's ability to process and clear ammonia and other toxins. This patient is toxic. These substances can accumulate in the bloodstream and can cross the blood-brain barrier, leading to hepatic encephalopathy, which is characterized by confusion, personality changes, and can progress to coma if untreated. So we have our lab values. We know that this person has increased ammonia levels, etc. So usually your doctor's going to order a medication like KXLate, which is going to cause them to have a bowel movement and pull out some of that excess ammonia. Patients have to be watched closely because, again, the confusion can progress to a comatose-like state and, worst case scenario, death. Question 9. Which of the following is a classic sign of hyperthyroidism? Would it be A, cold intolerance, B, weight gain, C, tachycardia, or D, fatigue? A classic sign of hyperthyroidism. So whenever I think of hyperthyroidism, I think of somebody with a really fast metabolism. And because of that fast metabolism, their heart rate's also going to be fast. So it is C, everybody. Hyperthyroidism accelerates metabolism. So it can cause increased heart rate, weight loss, and also heat intolerance. They're going to be hot, okay? Question 10. A client with COPD, which is chronic obstructive pulmonary disease, is receiving oxygen therapy at 2 liters per minute via a nasal cannula. What is the primary concern? Would it be A, hypoventilation due to CO2 retention, B, atelectasis, C, pneumonia, or D, pleural effusion? And if those are some new terms, you need to be looking those up also. So COPD, chronic obstructive pulmonary disease. All right. And so the answer would be A. It would be hypoventilation due to CO2 retention. So whenever a client has COPD, they often retain CO2. And so too much O2, if you give them too much oxygen, is actually going to decrease their drive to breathe. So a COPD patient usually has a low flow oxygen at a rate of 1 to 2 liters. And so here are some classic symptoms of a patient with COPD or chronic airflow limitation. And so they can become easily fatigued. So just getting them up and walking them to the bathroom may be a challenge. They'll have frequent respiratory infections. They'll use their accessory muscles to breathe. They would be orthopnic. They can be thin in appearance because of the work of labor. Sometimes they don't eat as well. Wheezing, pursed lip breathing, a chronic cough, a barrel chest, dyspnea, and also prolonged expiratory time. And if you look at their fingers, sometimes they have nail clubbing or digital clubbing. That would be signs of a patient who has COPD. And usually that emphysema comes from long-term smoking. So this person has probably smoked in their life, or they have lived with somebody who smoked. Question 11. What is a primary symptom of pulmonary embolism? Is it A, increased urine output, B, sudden shortness of breath and chest pain, C, bilateral leg swelling, or D, fever and productive cough? All right, giving you about 5 more seconds. So 4, 3, 2, and a priority symptom would be, you are right, it is B, shortness of breath and chest pain. And so that would be hallmark signs of a pulmonary embolism, especially if it occurs after a surgery. So if they had a orthopedic surgery or if they were under anesthesia for a long time, that blood isn't circulating because they're not moving about. And so usually after surgeries, that's why we try to get those patients up. We put those sequential compression devices on their legs to circulate some blood, but sometimes those clots can travel and they can be lodged in the lung, and that is when they would start having that acute chest pain and also shortness of breath. And so as a nurse, we know that you're going to be notifying a physician, and then of course, listen to your patient, notify the physician, and then from there, they can do VQ scans, they can do multiple tests, maybe a bronch, to figure out what's happening. Also a CT scan to figure out what's happening to your patient and what's causing these acute symptoms. Question 12. A client is receiving IV furosemide or Lasix. What lab value is most important to monitor? Would it be A, sodium, B, BUN, C, magnesium, or D, potassium? All right, so whenever a client or a patient is receiving Lasix, you always want to monitor D, potassium, because Lasix, when it pulls out the excess fluid, it pulls out potassium also. And so low potassium can cause hypokalemia, which can cause cardiac arrhythmias. Or you're going to see an abnormal EKG reading. Or if they have the telemetry monitor, you may start seeing some PVC, some abnormalities. So if a patient's on Lasix, it's automatic. You have to be checking their blood work daily, such as their BMP, which will show their potassium levels. Question 13, which is a classic sign of acute cholecystitis? Would it be A, Murphy sign, B, left lower quadrant pain, C, Cullen sign, or D, Babinski reflex? Oh, let's see if you remember from nursing school. A classic sign of acute cholecystitis would be, yep, A is an apple. It is Murphy's sign. So a Murphy sign is when a person feels a sharp pain on inspiration with right upper quadrant palpation. So when you go in and you press in the right upper quadrant, it makes them stop breathing and they have sudden pain. Whenever the provider gently presses under the right right side of the ribs while they take a deep breath in. So you're going to tell your patient to take a deep breath in as you push in. And so, ouch, they're not going to want to breathe. It's going to be really painful. This is a classic sign of acute cholecystitis, which means the gallbladder is inflamed and painful. And what do you think the orders are going to be? Remember, I'm here to help you think critically. Do you think this patient's going to be on a regular diet? No, you're about to call the doctor. They're more than likely about to be NPO. We need to give that gallbladder their body time to rest. All right, question 14. In anemia, what is most concerning? Is it A, elevated hematocrit, B, polyuria, C, increased heart rate and dizziness, or D, bradycardia? So, anemia, we have a low red blood cell count. And so if someone is anemic, it is going to be C. You are right. Increased heart rate and dizziness. So when when someone is anemic, their body doesn't have enough healthy red blood cells to carry oxygen. This can make the heart work harder to pump more blood and oxygen to the body. And so the heart's pumping fast, but they're anemic. There's no blood. There's no oxygen. And so even though the heart is beating fast, it doesn't result in increased cardiac output. And therefore, the lack of oxygen, the lack of red blood cells, this patient is going to become dizzy. So fast heart rate dizziness is very concerning because the body is trying to compensate by that heart beating faster for this person's low oxygen level secondary to the anemia. And this could cause that patient to pass out. So what do you think happens next, future nurses? Your patient, you have your CBC. That's where you see your your H and H's, your red blood cell counts, your white blood cell counts. So you have your CBC, you have your labs. You're calling the doctor to tell them that the patient's dizzy. I want you to be thinking about anticipating these orders. What do you think your doctor's going to order? And that's right. If you said a possible type and screen, because this patient not only may need fluids, but they may also need a blood transfusion if they agree, you are right. Question 15. A client with suspected stroke must have a CT scan done promptly to determine. Would it be A, blood glucose levels, B, blood type, C, if there is right or left-sided weakness, or D, the type of stroke, whether ischemic or hemorrhagic? So a client with a suspected stroke, why must they have a CT scan immediately upon arrival to the hospital? Is it to check their blood glucose level, to check their blood type, to see if they have left or right-sided weakness, or to see what type of stroke they had? Thumbs up. Great job. It is D. So we need to determine whether or not they had an ischemic, which is caused by a blockage, or a hemorrhagic, which is caused by an aneurysm, an opening in a vessel. Because based on the type of stroke they have, it's going to determine the treatment. And so if it's ischemic, we can give clot busters, we can give TPA. But if it's hemorrhagic, this person probably needs to go to surgery. And so, yes, regardless, they're going to be NPO. We have to get the CT scan done, but giving someone a clot buster versus having cranial surgery, that's two different levels of treatment. And so usually door to, CT scan for some facilities is about 30 minutes. So when they call a code stroke, we have to get the ball moving pretty fast. Question 16. The most common cause of pneumonia in the elderly is it A, Pseudomonas aeruginosa? All right, don't judge me. I pronounce all the other words correctly. B, Staphylococcus aureus. C, Streptococcus pneumoniae. Or D, I'm going to say is E. coli. All right, so if a person has pneumonia and they are elderly, what is the primary cause? All right. Revealing the answer in 3, 2, and you all. It is C, Streptococcus pneumoniae. And so the leading cause of community-acquired pneumonia, that means they're hanging around their buddies, they're in a nursing facility, or, they're playing bingo, community-acquired pneumonia, is because of Streptococcus pneumoniae. So in older adults, that's the most common germ that causes pneumonia. It's also called pneumococcus. It's a bacteria that often lives in the nose and the throat and can cause serious infections like pneumonia, especially when someone's immune system is weaker. 17. What is the most classic symptom of Parkinson's disease? Would it be A, resting tremor, B, confusion, C, intention tremor, or D, polyuria? So if one of your patients has Parkinson's disease, what you're going to notice is A, a resting tremor. So resting tremors are hallmark signs of Parkinson's disease. And even if a person does have Parkinson's, that doesn't mean that they have dementia. It doesn't mean that they have confusion. You can have one without the other. However, you still have to allow them time to speak, to communicate, because sometimes they do have like expressive aphasia. And then something else they may have also is because of the tremors, you want to use adaptive utensils, maybe utensils that have a bigger handle, so they'll be able to feed themselves independently, even though they have the tremors. Question 18. A client's lab shows a WBC of 15,000. What is this called? So WBC would be their white blood cell count, and it's 15,000. Would this be A, neutropenia, B, leukopenia, C, lymphopenia, or D, leukocytosis? Know a lot of medical terms. As nurses, we have to learn so much. But the great thing is that once you get through going through all of your schooling and then you finish your last rotation, you get to specialize. And so if you want to work with infants, that would be the NICU. You want to work with kids, that's pediatrics. Me, I chose cardiology. So that would be telemetry and ICU. So you do have to learn a whole bunch in order to pass the NCLEX, the national examination for you to become a nurse. But then after that, you can really focus and hone in. And so for question 18, if you chose D, you are right. So a WBC count of 15,000 is higher than normal. The normal range should be about 4 to 10,000. So when someone's white blood cell count is elevated, it's called leukocytosis, and that usually happens because they're fighting an infection or inflammation, or they're extra stressed. And so elevated WBC, automatically be thinking up infection, inflammation, what's going on to stress this person's body out. 19, and we're going all the way to 30. A client with acute gastrointestinal bleeding suddenly becomes restless with a rapid heart rate and a blood pressure of 85/50. What is the primary action? Would it be A, check capillary refill, B, start a large bore IV and begin fluid resuscitation, C, call the provider for a proton pump inhibitor order, or D, give an antiemetic? So GI bleed, acute, fast heart rate, low blood pressure. What are you thinking? Yes, it is B. This patient's bleeding out. So restlessness, tachycardia, and low blood pressure means hypovolemic shock. They don't have any volume. Okay, so we have to replace volume right away. Yes, they're probably going to need surgery. Yes, they're probably going to need blood transfusion. But for right now, you go get those IV fluids. So priority is stabilizing circulation with IV fluids until we can get that type and screen, until we can get the surgeon there, until we can get some other measures implemented. 20. A client is receiving IV morphine for severe pain. Which vital sign must you monitor most closely? Is it heart rate, blood pressure, respiratory rate, or temperature? I mean, all of the vital signs are important, but one is especially important if you're given morphine. Which one is it? I see you, and I see that you chose C, which is absolutely correct. So, medications such as morphine can actually cause respiratory depression. And so, you have to go in and you have to count their respiratory rate. It's going to be C. So, opioids like morphine can cause respiratory depression. Always monitor the client's breathing. Don't forget, how do we reverse an opioid? What medication do we administer? So you got to be thinking about that. If your patient's taking an opioid like morphine, there's a possibility that they can go into respiratory distress. How do you reverse it? And if you said naloxone or Narcan, you get an extra bonus point. And question 21. In a client with SIADH or syndrome of inappropriate ADH, we most often see which of the following. So think about the endocrine system when you think about SIADH. Would it be A, polyuria and dehydration, B, fluid retention and hyponatremia, C, low ADH levels, or D, dilute urine and hypernatremia? Oh, this one's hard. All right. Revealing the answer in 3, 2, and I want you to think about soaked on the inside whenever you think about SIADH. So it's going to be B. They are soaked. They are retaining so much fluid until even if they had a normal sodium level, because there's now the same amount of sodium in a large amount of fluid, they have low sodium counts or low sodium levels. So excessive ADH causes water retention and dilute sodium. And so this person can start having seizures. Their urine can become really sticky. And so if you start noticing these changes in your patient, you want to be ordering, of course, some blood work, but also we have to monitor their fluids too. So that would be some of your endocrine system disorders, and we'll discuss that in a future video. Question 22. A client with renal failure is most at risk for which imbalance? Would it be A, hypocalcemia and hyperkalemia, B, hypokalemia only, C, hypercalcemia, or D, hypercalcemia and hypokalemia? That's a lot. Let's break it down. Renal failure. The kidneys aren't working. We kind of talked about this before. When the kidneys are not working, that means it's not excreting certain electrolytes. One of the electrolytes we mentioned was potassium, right? And so if they're not excreting potassium, would it be low or would it be high? So it's going to be high. So which of these terms refers to high potassium? And that's going to be one of the answers that I give you. That's the only hint. All right, revealing the answer in 3, 2, and yes, it is A. It is hypocalcemia, low calcium, but then hyperkalemia, high potassium levels. So poor kidney function retains potassium, but it also reduces calcium. And don't forget that on the EKG, whenever someone has high potassium levels, sometimes you would see your QRS complex and then a spike T behind it. So you can also tell when a person's, let me rephrase that. So when a patient is having low potassium levels and also high potassium levels, either or can definitely cause changes on the EKG. So your patient should be on a telemetry monitor. Question 23. A client is post-thyroidectomy. What is the most important bedside equipment to have? So they had all or a portion of their thyroid removed, post-thyroidectomy. What is the most important bedside equipment to have? Would it be A, oxygen and an ambu bag, B, IV fluids and an infusion pump, C, a tracheostomy set, or D, a non-rebreather mask? I'll give you a few seconds to think this one through. All right, revealing the correct response in 5, 4, 3, 2, and you all, we just performed surgery on their neck area. We may want to have C, a tracheostomy set. So after thyroidectomy or the thyroid removal, swelling or bleeding in the neck can happen that can block the airway. If that happens, you need to be ready to quickly secure an airway. So a tracheostomy set at the bedside is most important in case they can't breathe. As a nurse, we're not doing the emergency tracheostomies, but we will be the ones who are calling the rapid response team, who's calling the intensivists and the critical care doctors in the room, and they can perform that bedside tracheostomy if needed. You monitor your patient and then notify the physician in case of any changes. 24, a client with asthma is wheezing loudly, then becomes silent. What is your priority as a nurse? Is it A, begin and send on spirometry, B, notify the healthcare provider, C, observe, because if they stop making sounds, they were wheezing loudly, now they're silent, that must mean that they are improving, or D, give nebulized bronchodilators and prepare for possible intubation. And if you haven't done so already, go ahead and give us a thumbs up, give us a heart if you're in the chat, if you're enjoying this video. I love teaching you. I love sharing knowledge with you all. So thank you for being a part of my online community of students. Question 24, the answer is D, you all. If a client with asthma is wheezing loudly, like audibly, like you can hear it without a stethoscope, and then it goes silent, that means that there is no air moving. That means they have a silent chest. That is very dangerous. That is a medical emergency because their airway is closed up. There's no air exchange. You need to act immediately by giving that bronchodilator to open up the airways and prepare for possible intubation if the client still cannot breathe after you give them their medication. 25. Let's talk about our drugs. So acetaminophen or Tylenol, what is a serious risk at high doses? So if your patient takes too much Tylenol, what could possibly happen? Would it be A, kidney failure, B, liver failure, C, heart arrhythmias, or D, stroke? And you should know this one. I have faith in you. I think you're torn between A's and B's, but if you chose B, you are right. So acetaminophen can cause serious liver damage if you take too much. The antidote for overdose is acetylcysteine or mucimist. And remember, the maximum safe dose for Tylenol or acetaminophen is 3,000 to 4,000 milligrams per day. So if your patient's overdoing it on the Tylenol, and then on top of that, they may already have liver damage that we're not made aware of, they're going to make their liver damage worse. And that's when you would see jaundice, etc. So if a patient has liver failure, more than likely they will not be prescribed Tylenol, and or they're going to have like a very low dose so that we are nowhere near their maximum safe dose, because the maximum safe dose of 3,000 to 4,000 milligrams is safe for somebody who does not have liver failure. If they have liver failure, the safe dose is going to be a lot less. Question 26, drug class. So benzodiazepines such as diazepam and lorazepam, what is the FDA black box warning? Yep, use those drug books, use those physician desk resources. When you look at your drug books, they have a black box warning. That means that that is something that you have to know as a nurse. And so would a benzodiazepine cause A, serious skin reactions, B, risk of respiratory depression when combined with opioids, C, a risk of bleeding, or D, increased suicidal thoughts? What is in the black box warning from the Food and Drug Administration or FDA? Yep, it is B. So benzodiazepines can cause serious sedation and slowing of breathing, especially if mixed with opioids. So one potentiates the other. One causes the other medication to work better. And in this case, that means that, hey, if you're really sedated, that means you're going to slow down your breathing. So this is their black box warning. Always monitor for too much sedation. And as we already said, you're going to have some reversal agents nearby. But the best rule of thumb is to check the vital signs before you give them benzodiazepines, and don't give benzodiazepines and also the opioids at the same time. 27. The most common cause of myocardial infarction or MI is A. Heart valve dysfunction, B. Coronary artery spasm, C. Mitral valve prolapse, or D. Atherosclerosis and plaque rupture. So, myo being muscle, cardial referring to the heart, infarction being death. Which of these would be the most common cause of heart death or a heart attack? Yes, it is D. So, a myocardial infarction or a heart attack happens when part of the heart muscle does not get enough blood. The most common cause is atherosclerosis, which is a buildup of fatty plaque inside of the arteries. When one of these plaques ruptures, a clot forms quickly at the site and blocks the coronary artery. This stops blood flow to a part of the heart, which can cause damage or heart death of the heart muscle cells that's caused a heart attack. And so that's when, if it's a man, they're going to have those classic doom and gloom symptoms. They're going to feel pressure or pain in their chest that radiates from maybe their jaw down their arm. They may begin sweating. They may feel nauseated. A lot of times they have epigastric symptoms. Of course, we're going to order EKG. They may also need to be taken to the cath lab. We have to see if, what's going on, so they can do a percutaneous coronary intervention. They can go in and get an internal view of the heart. Unfortunately for women, we don't usually have those classic signs. So if you have a female patient who's just complaining of back pain, it's like, oh, it's not moving. My back is hurting. On a scale of 0 to 10, it's a 7, it's an 8. I need for you to be thinking about, is it a possibility, especially if she has hypertension or she has diabetes, is it a possibility that she's having an MI or a heart attack? Notify your physician. If what you're doing to alleviate her pain isn't working, notify the physician, get an EKG ordered. I've literally had a patient having a massive MI and her only complaint was back pain. Fortunately, we were on a telemetry unit and her doctor had, time to get her down to the cath lab, and she had a stent placed. So women, we have atypical symptoms. 28. In a client with COPD, a client with COPD should have a target oxygen saturation of which of the following? Is it A, 90 to 94%, B, 99 to 100%, C, 95 to 100%, or D, 85 to 89%? What is their target oxygen saturation? Think about what we talked about earlier with COPD. If they get too much oxygen, it decreases their drive. They won't breathe. And so for them, our target would never be close to 100%. Instead, it is going to be A. So the target oxygen saturation is 90 to 94%. So 1 to 2 liters, that's all they're getting, because people with COPD often have long-term changes in their lungs and can become used to lower oxygen levels. If we give them too much oxygen, it can decrease their drive to breathe. That's why we aim for slightly lower but safe oxygen saturation of around 90 to 94% to keep them comfortable without slowing their breathing. Question 29. A client with acute pulmonary edema due to congestive heart failure is receiving furosemide IV. What was another name for furosemide? Lasix. All right. So, and supplemental oxygen. Their O2 sat is 85%. That's major. And they are anxious with pink frothy sputum. What is the next best action? Let's read that. They're getting IV furosemide. So that tells me that we're trying to pull this fluid out. They have pulmonary edema. Maybe it's related to congestive heart failure. And then on top of that, they have supplemental oxygen. So even with the oxygen, their O2 sat is 85%. They're anxious due to the lack of oxygen. And now there's pink frothy sputum coming up. As the nurse, would you do A, would you place them on a nasal cannula at 4 liters per minute? Would you do B, place the client in a high phallus position and prepare for CPAP or BiPAP? C would be increase the IV fluids to improve perfusion, or D would be start a nitroglycerin drip to improve preload and afterload. I know you got this one right because I know you know that whenever someone's having breathing problems, we're going to change their position. That's one of your first interventions. So you all, it is going to be B. Severe pulmonary edema requires aggressive respiratory support to improve gas exchange. And so we're going to get them upright. Of course, you're going to call rapid response. Sometimes when a patient's on a CPAP or a BiPAP, they may have to be changed to a different level of care because it requires closer monitoring. And so if you're on a med surg unit with 8 patients, and this patient is so acute right now, more than likely they're going to move them to another unit. So with a nurse that only has 1 or 2 patients, depends on your hospital. But a CPAP and a BiPAP will help to keep the alveoli or the air sacs at the very base of the lungs open, and it helps to decrease the work of breathing. But because of this patient's acute state, they probably will be taken off of your floor. Question 30. A client with acute spinal cord injury at C5 is showing bradycardia and hypotension. What is the most important action? Is it A, administer atropine and vasopressors to treat neurogenic shock? B, encourage coughing and deep breathing exercises? C, increase head of bed elevation to 45 degrees? Or D, reduce IV fluids to prevent overload? All right, and so in this particular question, this patient is bradycardic and they're hypotensive. How do we treat it? How do we treat bradycardia? How do we treat hypotension? The fact that they have a spinal cord injury, that is also relevant, but I want you to be thinking critically right now. My patient, they're bradycardic, they're hypotensive, I need to fix it. I'm going to fix it with A. We're going to administer some atropine and vasopressors in order to treat the neurogenic shock. So surgical spinal injuries can cause neurogenic shock, what means the heart rate can drop. And because of low cardiac output, the blood pressure also can drop due to the loss of sympathetic tone. We treat it with atropine and then vasopressors like dopamine or norepinephrine. And again, if all those are terms that you're not so familiar with, by the time you get to your critical care rotation in nursing school, this is going to be second nature. These are going to be terms that you hear a lot. And so you all, I have appreciated spending this time with you. If you're interested in learning more about basic life support, advanced cardiovascular life support, or pediatric advanced life support, even CPR instructor classes, we have a full playlist on our YouTube channel. So as you see, youtube.com/Florida training. You have to be learning what to do. If you're afraid to run a code, I understand. I've been there too, but it makes you a safe caregiver because when your patient's heart rate is low, when it's fast, or when their heart stops, I need you to know what to do because you are the difference. You're going to be the one who can activate the rapid response team and manage the code until they get into your patient's room. And so we'd rather you prepare and that you know what to do, even if you never have to use it. And so learn those codes, and you can do so on our YouTube channel. You all, thank you for watching. Again, if you haven't subscribed, please subscribe to our channel. Don't forget to like and share. And I will see you at 9 p.m. That's right, in a few minutes, just for our our talk tonight. So we're going to be just talking, getting to know each other. So 9 p.m. Eastern Standard Time on a YouTube channel. This is Nurse Eunice, and I'll see you in the next